Thank you for your very kind presentation. And I'm very glad to be here. And of course, I hope that my presentation will be useful because it is a topic that is just apparently simple, but is not that simple indeed. The topic of pharmacotherapy and psychotherapy. Does it matter combining psychotherapy and pharmacotherapy in depression? This question could sound naive because everybody could think obviously it's better. But we will see during the presentation that this is not so simple. There are things to be considered in this combination and this activity. I don't see the slides. Slides on the main floor. Okay, I see now the slides. So let's go back to the first slide. Question is combining pharmacotherapy and psychotherapy. So as I said, it is apparently an easy question. Everybody would say, yes, two is better than one. But we will see in the next 25 to 30 minutes that this is not so simple. And it's better to consider specific aspects to be sure when is the right moment to use both of them or one of them alone. Let's start with history. Probably many of you are aware that 50 years ago, during the 60s and the 70s, there was a big debate about psychotherapy or pharmacotherapy. The main institutions in the US were all psychoanalytical institutions, and the biological psychiatry was considered in a very marginal way. And so in the 60s, in the 70s, there have always been a big fight between psychiatrists favoring drugs or psychiatrists favoring psychotherapy. This luckily went away and it changed a lot during the recent times, and therefore now we are in the position to have probably a wiser view on the topic. Therefore, we will present this topic facing some aspects. The definition that we will see is not so easy to discuss, and then we will see what's the evidence of efficacy of the combination compared to the standard treatment, long-term effect. We will briefly discuss the different psychotherapies, and then we will see an interesting point that explains much. So I put at the end probably the solution of the problem. The last slides are the ones that give an answer about the dilemma of psychotherapy and pharmacotherapy. But let's go step by step. The definition. The definition of psychotherapy is quite difficult, of course. What is psychotherapy? Is anything that we can do with the patient. So discussing, explaining, doing some structured psychotherapy, cognitive behavioral therapy, any other kind of therapy. We will face this in due time. But first, let's specify, just to be, let's say, easy and clear, what is not psychotherapy. That is much easier than describing what is psychotherapy. There has been a long line of publications about the problem of the doctor-patient relationship in many specialties, including psychiatries. And the point is that it is quite surprising that the average time when the doctor and the patient meet in the hospital or wherever, that the patient is asking what's the problem, explaining his needs and desires and problems. Usually it is around 11 seconds. Some research say 18 seconds. It means that after 10, 20 seconds, the doctor usually interrupts the patient, and then start asking direct questions. This, of course, is mainly due to the pressure of time that specialists have and psychiatrists too. But of course, the outcome of this is that the patient-doctor relationship is somehow impaired. You can understand that if you don't let the patient express their needs, it's quite difficult to create a therapeutic alliance. So this is a problem in many specialties, including psychiatry. So to let the patient talk 11 seconds or 20 and then start doing some questions is probably not psychotherapy, particularly if the consultation lasts 5 to 10 minutes and therefore there is no time for any kind of exchange. And therefore, the idea of psychotherapy is extremely difficult to find. I searched in the years which is the best definition of psychotherapy, and you can find so many definitions that at the end there is no definition at all. We can say that psychotherapy is clearly a very broad concept, very broad, because our psychiatric consultations, what we do every day, I am a clinician, I'm professor of psychiatry, so I see patients every day. Our psychiatric consultations usually include a variable degree of psychotherapy. Obviously, when we are with the patient, we are doing something. My first contact with the patient usually lasts 45 minutes and includes some kind of psychoeducation and some other psychotherapeutic tools and strategy, not formal psychotherapy, but some kind of psychotherapy. That's called eclectic psychotherapy. And also the frequent consultations, you do something, not just ask about side effects of drugs, we will talk in the next presentation, or sleeping, or very simple symptoms, but you do so also some level of psychotherapy. This is very variable in the world. I've traveled quite a lot in the last 20, 30 years, and I have seen so many different realities. Just to give you an idea, in Japan, the psychiatric consultation usually lasts 5 to 10 minutes. It's difficult that goes to 15. So you understand that in that environment, psychotherapy is not common at all. In Mediterranean countries, it's probably the opposite. In Italy, consultations are in the range of 30 to 45 to 60 minutes for patients, and in Spain, similar, and other variations all over the world. I heard that also here in Turkey, you have sometimes different track for pharmacotherapy that could be between 15 or 20 minutes, and psychotherapy that is 1 hour. Another concept we will discuss during this presentation is the patient variability. First, not all patients want to be treated with psychotherapy. At least in my experience, I have at least, I would say, 1/3 or even more patients that they say, no, doctor, please give me the pill, explain me which is my disease, but I don't want to undergo to a psychotherapy, a formal activity or any kind of it. It happens. So if there is a preference from the patient, this should be respected. Second, the preference of the psychiatrist. We will see later that not all psychotherapies are good for all conditions. There are some psychotherapies that are better for personality disorders, some other for psychotic disorders, some other for depression alone, other for depression and comorbidity. So there is a big mix of things to be considered when we have to match the patient and the psychotherapies. And then the last point is that formal psychotherapy, as we will see later, much overlap one to another. Interpersonal psychotherapy compared to cognitive behavioral psychotherapy compared to some others, they don't differ 100%. They have many points in common. And these points in common make it difficult, as we will see later, to see which is the best for depression, for example. So let's start with some numbers. Efficacy. Let's try to answer the question of the title of this presentation. Is better the combination of psychotherapy and pharmacotherapy or not? We have seen in the previous slide that is a quite a difficult question because it depends what you do in practice. So it's very difficult to do a trial where you do no psychotherapy at all on some patients and you do a combined treatment on the other. But provided that this is possible, which are the results? One of the first attempts is this one, NIH treatment program of more than 30 years ago. They combine some studies and try to answer this question. And the answer was very clear in the direction that the combined treatment, psychotherapy plus pharmacotherapy, is always better. And the only difference is that when you use only psychotherapy in severe patients, this case you don't have big results. And so this finding has been, I would say, almost univocally confirmed in the last, what was this, 30 years. And so the first take-home message that I would like to give to you today is that if a patient has a very severe depression, let's talk about very severe means above 25 points of the Hamilton, 25, 28 points of the Hamilton depressive scale. If a patient is such a level of severity, psychotherapy alone probably, I would say not probably, clearly doesn't work well as the combination with pharmacotherapy. And this is the first take-home message, but the combination works better. Years passed, and after a few years, there has been another very big study that combined more studies than the originals that you have seen in the previous slide, and they showed a very interesting result. The large majority of the studies that combine psychotherapy and pharmacotherapy, they have a better outcome in depression compared to the ones that, the arms that there is no combination. But you see also some kind of variability. For example, there is this study here, Minos-Wallis, that seems to be neutral or going in the opposite direction. And this gives us another point of information that is very useful. That study is performed on patients that are not very severe. They have included patients with a threshold of 13 in the Hamilton. That from a clinical point of view means that they are not very severely depressed. The threshold of normal depression, let's say, is 18, 20, 22. Severe depression, 30 or above. 13 is a condition that could be considered subclinical depression by some. So it's an intermediate depression. And there is a lot of evidence that antidepressants are not that effective in mild depression. And so this explains why in this study, for example, the combination of drugs and psychotherapy was not superior to drugs alone. And this is the second take-home message that I would like to give you today. The first was, for very severe depression, psychotherapy alone is not a good option. Severe depression needs pharmacotherapy. On the opposite, for mild depression, psychotherapy could be sufficient, and pharmacotherapy could add not much benefit. So now you start to understand which is the take-home message of this presentation. Psychotherapy and pharmacotherapy combination is clearly better only in the intermediate part of the severity. In the numbers, I would say from 20 of the Hamilton scale to 35, 40. If it is too severe, then psychotherapy does almost nothing, and so it's similar to pharmacotherapy alone, and the opposite and the low range of severity. This is true also for children. This meta-analysis performed in children shows very clearly that a combination CBT in this case with some specific antidepressants, three of them, imipramine, fluoxetine, and also placebo, is indeed more effective than drugs alone, as you can see in the middle, or no treatment or psychotherapy alone. So this applies also to children, that means below the age of 18. Also interesting is another approach that has been performed by one of the most famous worldwide experts of this kind of studies of psychotherapy and pharmacotherapy, that is Pim Kuipers. And he did a global comparison of combined versus not combined. And the results are very clear in all the directions. So in the first line, we see that combined treatment, psychotherapy and pharmacotherapy, versus psychotherapy alone is indeed better, significantly better. But also the other line is interesting because the combination of pharmacotherapy and psychotherapy is also better than pharmacotherapy alone. And similar results in the other lines. So the idea here is that you are starting to understand that for the majority of depressed people, the combination of pharmacotherapy and psychotherapy is beneficial. For the severity extremes, low severity or high severity, maybe it's not the case. And this is confirmed by our very recent study that we performed, this is last year, on very severe patients, treatment-resistant depression with high rate of severity. And indeed, we have seen what we were expecting to see. In those very severe patients, the combination of psychotherapy to pharmacotherapy is not adding much in terms of benefit because they are too severe. And this is, I think, also your clinical experience. When I'm treating a patient that is very high on Hamilton Depressive Rating Scale in terms of 40 or 45 of Hamilton, it's extremely difficult communication. There are cognitive distortions that are very hard to face in some kind of CBT or other kind of approaches. However, a mild effect on treatment-resistant depression has been shown by a very recent meta-analysis that is indeed mild, but it is present. Why this is slightly different from our studies? Because there is a big heterogeneity here. All those studies are not of very severe patients. Some include moderate severe patients. So in moderate severe patients, it's possible that the combination is useful also in treatment-resistant depression. But what is very, very interesting is this other result of the same meta-analysis. This other result is extremely interesting in terms of practical consequences. What they did, they selected 3 studies where in treatment-resistant depression, they didn't change the pharmacotherapeutic treatment. They keep the same and they added psychotherapy. This is not the standard because you know that in treatment-resistant depression we have an algorithm. You are not responding to sertraline, increase the dose. After 200 milligrams, you do a combination with another compound. In case of no response, you do a switch and then you do augmentation, the usual algorithm of treatment of antidepressant in treatment-resistant depression. So if you have a depressed patient that is not responding to a specific treatment, is not standard to not do any change. So a patient is not responding to sertraline, we go on with sertraline for 6 months. This is not standard. And they try to see if in those studies where you go on with the same unsuccessful treatment, but you add psychotherapy, if it is beneficial or not. I think this is a very, very clever question. But the answer is very clear. there is no benefit, or probably a small negative effect. That does not surprise because you need the combination of the two, as we will see in the later slides. If you don't support with the pharmacotherapy in severe depression and resistant depression, and you only add the psychotherapy, it's like using psychotherapy alone. And we know that in severe patients, psychotherapy alone is not sufficient. So I think this finding is very, very, very interesting. So in this first part, we have seen the definition that is quite difficult, the efficacy, and we have seen the short-term efficacy. Couple of slides on the long term. Long term is very important for depressed patients because patients have to be treated for a long time, particularly when depressed patients have 3 or 4 or 5 or more episodes. You need to go on for years with the antidepressant. And we all know that this part is very difficult because usually patients stop the medication. How many times they told me, doctor, I'm well since 2 years. May I stop my antidepressant? And then I have to discuss and explain, listen, you are well since 2 years, right? But you had 5 very severe, maybe psychotic episodes. It's quite dangerous to stop the medication now. So this happens, I think, also in your clinical practice very frequently. And therefore, if they stop the medication, you know that a very high rate of them relapse sooner or later. And this is why it's important to see if psychotherapy is useful in this case. And the results here also are very clear that the psychotherapy in the long term, that means over 1 year, are even better than in the short term. And this is not surprising because if you do some kind of psychotherapy at every meeting for 12 months, you improve the compliance, the therapeutic alliance, and so you reduce a lot the risk of dropout and the risk of stopping the medication. So this is useful, but this is also an indication that we could either use a psychotherapist on our behalf together, or we can do this work in our everyday clinical practice, depending on the time, of course, and depending on the patients. So summarizing this first part, how much better is the combination of the two in the intermediate part of severity of depression? Well, what's very interesting that two things are very interesting. First, the so-called effect size. Effect size is how much better it is, the combination, is in the range of 0.304. That is usually considered clinically relevant. This is technically 1/3 of standard deviation. So it is a lot. Number needed to treat 4 and number needed to treat 5. It is a lot. So adding psychological treatment to medication gives a relevant benefit that is more or less the same benefit of adding medication to psychological treatment in intermediate depression, excluding the extremely severe and the extremely mild. Therefore, the effect is more clear in moderate depression. However, there are a lot of limitations to be considered in this finding. There are some studies, like this one, that question the validity of the approach of the study. And you can imagine that to do a study, such a study, is extremely difficult. How do you standardize the treatment, interpersonal therapy, cognitive behavioral therapy, the variability across the treatment that you give to the patient? And sometime the variability, this paper is very interesting because sometimes the variability across treatments is almost zero because at the end the procedure of psychotherapy is very similar. CBT or interpersonal or other psychotherapies. The fact that you go once a week to a doctor to talk 45 minutes, it's not so important what happens within those 45 minutes, but it's important that it happens. So this has been questioned as a bias in comparing the different psychotherapies. And the other bias is that the treatment as usual is rarely completely treatment as usual. What is treatment as usual? That the psychiatrist just writes the name of the compound and asks about insomnia, constipation, nausea, and so on. It's difficult. Usually the psychiatry does some level of psychotherapy. So as you understand, it's very difficult to do these studies, but with these limitations, results are these ones. Couple of slides about psychotherapies. We have seen that the definition of psychotherapy is quite challenging. Everything could be considered psychotherapy. Also, listening to the patients, empathic listening is considered psychotherapy. Indeed, my collaborator Raffaella Calati in a book listed the most important psychotherapies. And there are a lot of psychotherapy. These are just some. They are, I think, more than 50 different kind of psychotherapies. Not to mention all the new online approaches that are used with some of these psychotherapies or even new ones. So which is the psychotherapy that we should use? Because we have talked about psychotherapy, eclectic psychotherapy, cognitive, behavioral, interpersonal. There is the famous dialectical behavior therapy, probably better when there is a comorbidity with borderline personality disorder. So there are so many psychotherapy. One answer comes from this very large and recent network meta-analysis. I'm usually not very in favor of network meta-analysis because, in my opinion, results may be biased. But this one, I think, could give us some interesting information. Andrea Cipriani, that is one of the authors, my friend from Italy, did a very nice job to compare all the psychotherapies that we have, or the measure psychotherapies that we have for depression, without drug, just psychotherapy. Results are very, very interesting in my opinion. First, starting from the bottom, you should read in the line direction. Starting from the bottom, the last line is placebo. Placebo means doing a pill, just a pill, placebo pill with nothing inside or sugar. So the pill placebo is clearly worse than any other kind of psychotherapy, but really worse, more, about half standard deviation. So it's really worse. Good. So this is interesting point. Another interesting point is the second line, that is even less than the pill placebo, is the waiting list, that is doing completely nothing. So the patient is just waiting for consultation 2 months at home. And this, of course, is the worst possible outcome because you do completely nothing. This is the natural history of the disease without any external influence. And of course, it works even less than placebo because at least placebo has the placebo effect. The waiting list has no placebo effect, has nothing. So this is very interesting. Let's go up and we see that the care as usual, that is some kind of meeting, psychoeducation, but very mild, is better than placebo or waiting list. You can see the direct comparison here, but you will see that in the slides better, but less than the all other psychotherapies. And then let's move up in this 1, 2, 3, 4, 5, 6 lines here in the top. That is very, very interesting. Here we see that all the most common psychotherapy, cognitive behavioral, interpersonal, what is there, the behavioral activation, the problem solving, all the most common psychotherapies, they are all similar one to another in terms of efficacy. Very similar, in the range of minus or plus 10%. So this is, I think, the definite answer to the people that says, oh no, cognitive behavioral is better, interpersonal is better. No, 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 no. In the very large numbers, they are all equal. And they are better than nothing, and they are better than placebo pill. And I tell you also results from other slides, and they are almost equal to antidepressant pill in general. And if you combine them, you have an even better outcome of about 1.3, 1.4 that we have seen in the slide before, except for the extreme severity. I think this finding is extremely interesting. But then there is also the issue of specificity, because if overall they are similar one another, it doesn't mean that they are good for all the patients. When there is a personality disorder comorbidity or patient preference, I had a patient who told me, oh, doctor, I've been 3 times in a psychodynamic psychotherapy. I really didn't like it. It was very frustrating for me. She was not speaking. I had to do everything. I didn't like. So there is also the personal preference and the fitting with the disease. Psychoanalytic and psychodynamic treatment are not indicated for psychotic patients, for example. So this tells us only that they are overall similar, but doesn't tell us to which patient we should apply each of them. To try to solve partially this problem, a few years ago we did a very interesting trial with meditation. Me and my colleague Alberto Chiesa are very fond of meditation as a technique. This is the mindfulness meditation. And so with patients that had, in this case, were depression, but we did another paper also on anxiety, and results are similar, with partial improvement. They were treated with the usual treatment, paroxetine, sertraline, escitalopram, and they had partial improvement. You see the Hamilton rating scale at the the inclusion in the study was in the range of 16, 18. They were coming from 25 or 26, so partial response. And then we divided in two groups in a random way, and in one group we did, I think 12, I don't remember, 12 sessions of mindfulness, and the other treatment as usual, just psychoeducation. We were very surprised to see that mindfulness was very, very more effective compared to treatment as usual, but in the range of what is 5, 6 points, that is more than half a standard deviation. So it's a relevant effect. So can we conclude that mindfulness is good for residual symptoms in depression? Don't know. Maybe it's a possible suggestion, but it's a first step to see which is the specificity of the treatments. Let's go to the last point, the last slides of my presentation. We have learned that psychotherapy and pharmacotherapy are good when combined, even though not in all patients. But we don't know why they are good to be combined, which are the mechanisms behind. And luckily, we have this possibility now. There are a lot of interest in the world at present to try to understand how we can improve the treatment of depression. One approach is to try to improve the plasticity. Small parenthesis. You all know probably that the improvement of depression when a depressed patient heals after 4 weeks is because the brain somehow grows. So the plasticity of the neurons, the new synapses in hippocampus, in the frontal cortex, in the cingulate cortex, so the healing of depressed patients is the rewiring of the areas that are somehow not functional in depression. So our strong aim is to improve the plasticity of the brain. Antidepressants indeed improve plasticity. Psychotherapy induce plasticity, we will see this later. But we could also work on other mechanisms that are changing the histones and the epigenetics of the DNA. So we can free some of the genes that allow for a better outcome in treatment. So some authors, like these ones, suggest to use, for example, valproate. Valproate is acting on the histones, and therefore valproate has an epigenetic effect. So the idea is that if we give valproate that activates the opening of some genes in the brain, and we do psychotherapy, we have a synergic effect, a long-lasting effect. From what I know, this is still theory and has not been widely tested yet, but is very interesting. Similarly interesting is another approach that is quite common now worldwide. I think it was in Turkey and is for sure in UK and US, where they are combining ketamine. Ketamine, you know, it is giving a very rapid antidepressant effect, but this rapid antidepressant effect is due to also to the plasticity that induces. Ketamine is inducing a lot of plasticity in the brain. And so some people say, why cannot we use this plasticity induced by ketamine combined with psychotherapy? We would have a much better effect. Trials are ongoing, and from what I heard from my colleagues, results are very, very interesting. And the last two slides are about the answer. I promised you at the beginning of the presentation an answer of the question that is going on since more than 50 years, psychotherapy, pharmacotherapy. And I like a lot the answer that is coming now, this is last year, that explains what happens. Look at what happens. This imaging, in my opinion, is fantastic because in the top, we see what happens in the terms of change. And the laser is not so strong, but you can see the green dots. The green dots is where there is an improvement when you treat patient with antidepressants. And the orange dots is the place where you see an improvement when you treat patients, depressed patients, only with psychotherapy. And what you see is very, very nice because they are different regions. So it means that both of them improve from depression. Both of them are well after a few weeks, but through different mechanisms. Antidepressants shut down the amygdala and hippocampal malfunction in a passive way, in a direct way. Psychotherapy activates the frontal cortex and the gyrum cortex in an active way to shut down the malfunctioning amygdala and the hippocampus. And so you understand from this picture why psychotherapy and pharmacotherapy are complementary, because they go in different areas of the brain that are converging. And this is the last slide of my presentation that summarizes this very, very interesting concept. So, on the left, you see what's happening in the brain of a patient that is suffering from depression and anxiety. You have a very active amygdala. You know the amygdala, we have two amygdalas in the limbic system. The two amygdalas are hyperactive, and an hyperactive amygdala is spreading fear, tension, insomnia to all the frontal cortex and the rest of the brain. With the use of antidepressants, we just shut down the amygdala in a direct way. But if we do also combine psychotherapy, top-down, the anterior cingulate cortex and the dorsolateral prefrontal cortex, that are what is psychotherapy doing? Thinking, behavior, cognitive, behavioral, interpersonal, then we have a two-way winning on the disease. With the antidepressants, we shut down the amygdala. And with psychotherapy, we reinforce the control, cortical control on the amygdala that is already shut down by the antidepressants. And then we much more easily reach the cure, the normalization of the system. So I hope that you like this concept as I liked the first time that I studied, because in my opinion, it cleared my mind in a wonderful way. And I use this with my patients when they ask me, what should I do, psychotherapy, pharmacotherapy? And depending on the patient, depending on the condition, I explain to them this slide. I say to them, listen, in your brain now there is an imbalance. Your limbic system is too active. Your frontal cortex cannot interact. And then you have insomnia, anxiety, sadness, lack of concentration. We can add on both these mechanisms with antidepressants and some level of psychotherapy. Be, 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 be relaxed, because in 2, 3, 4 weeks you will feel better. This is what I say every day based on this evidence. So, in conclusion, psychotherapy and pharmacotherapy. Well, the definition of psychotherapy is not that straightforward. Everything could be defined psychotherapy. There are formal psychotherapies, manualized psychotherapies, but then it depends how you use them. Eclectic psychotherapies, very long psychoanalytic training. By the way, I had some kind of psychoanalytic training, which is different, very different one from another. But the take-home message is the combination of both is almost always better, depending on the severity. Small severity, psychotherapy alone could be enough. Very high severity, pharmacotherapy alone probably is needed. In between, both of them is better. But you need a large degree of personalization because of the preference of the patients, comorbidity of the patients, and so on. And we learned that this cumulative benefit comes because different regions are involved, and therefore the effect is convergent. Hopefully, we can use the plasticity induced by some compounds, valproate, ketamine, psilocybin, to improve even more this synergy across the two treatments. And there are so many trials at present in the world. I was last week in Vienna in a congress, in CMP, and I was talking with the people in London, and they are doing studies to try to understand if this is working and how much. And finally, you know that I'm also working on genetics. The brain is different one from another. So of course, if we know the genetic background of each individual, we could do a more tailored treatment. But this is for the future. So thank you for your attention, and I'm here for your questions.